Sounds great. So I'm on the R3s. I will pause for questions, but if anything comes up, Nina, just let me know. I'm going to get rid of like all the faces so I don't get distracted. So I'm going to talk about non-alcoholic fatty liver disease, NAFLD. You might sometimes hear this referred to as MAFLD, metabolic associated fatty liver disease. They are discussing possibly changing the name, but for now, I'll just keep referring it to non-alcoholic fatty liver disease, but just so you know, in the future, that might be coming down the pipeline. Goals and objectives for today. Let me see. Not advancing. All right, let's do that. So goals and objectives. So we'll talk about the pathogenesis, we'll define it, we'll talk about some risk factors, we'll come up with a framework for working up these individuals, which I always get a little bit flustered in clinics. So I think it's great to have a way to think about it. And then basic initial management. Most of this talk is taken from the AHD guidelines. I've also talked about these slides with one of the hepatology fellows, and then I've talked to Dr. Best as well, who's one of the primary care hepatology specialists over at the VA. I will say that as we move through it, just let me know if anything comes up, and then what else was I going to say? I think that's it. I'll just kind of get into it and let me know if you guys have questions. So what is NAFLD? It's an entire spectrum of disease. So that's the umbrella term is NAFLD, non-alcoholic fatty liver disease. NAFL, non-alcoholic fatty liver, is hepatic steatosis, so fat in the liver. NASH is non-alcoholic steatohepatitis, so inflammation of that fat. And then cirrhosis from NASH is just like any other cirrhosis where you start to have a lot of scarring. I will say that there are a lot of etiologies that can cause fat accumulation into the liver, and we'll talk about those. So alcohol, based on the name, is one of them. You have to make sure that they are not drinking alcohol. There are some medications that can do it. Hepatitis C can do it specifically, although Hep B can sometimes do it a little bit too. So we want to make sure that we don't anchor on this diagnosis, but it is a diagnosis of exclusion that we always want to make sure we keep in the back of our minds when seeing patients that have fat accumulation in their liver. About 20% of NAFL will go to NASH, and about 20 to 40% of those with NASH will progress to cirrhosis. There's a lot of research going into to determine what risk factors predispose someone to having NASH versus progressing over to cirrhosis. And so we'll talk about it a little bit more at the end, but as of now, that we really don't know what those are. So some progress and some don't. And hopefully in the next few years, we'll be able to come up with a better algorithm to figure out who those people are. I will also mention that cryptogenic cirrhosis, so etiology unknown of cirrhosis. A lot of people believe that a lot of those are probably fatty liver disease. And now that we're looking for it more, we're going to see it a lot more. NASH can only be made with a liver biopsy. So you can't call anything NASH until they've had a liver biopsy. Until then, they're non-alcoholic fatty liver disease, or they're under the NAFLD umbrella term, and then they have to go on to a biopsy to be called NASH because you have to see that inflammation. What does that look like under the microscope? So you have your normal liver that starts to accumulate fat. So that's what you see there. And then you start to see inflammation around that fat. And then eventually that leads to cirrhosis. So why does that happen? And I think the pathophysiology is still not fully understood. The way that I describe it to my patients and the way that I've heard it described the best is that we used to think that abdominal fat doesn't do much. And now we think of it as a pretty powerful endocrine organ. It produces a lot of inflammation, which causes insulin resistance. And keep in mind, a lot of these patients are already overweight. They already have diabetes, possibly, or are pre-diabetic. So you already have some underlying insulin resistance. And then you have this fat that's increasing that. The pancreas increases insulin production because it thinks it's low since the insulin is not going into the cells. And then the liver sees all the insulin and thinks that you're in this feast mode and starts storing. So you have all these free fatty acids, all of this fat that's now getting stored in the liver. The fat itself can actually lead to inflammation, and it can affect the function of the way that the liver works. So it's kind of a two-hit. So you have all this inflammation, and then the liver, the fat in the liver causes inflammation as well. So that's the proposed mechanism, but there are others that, because there's some genetic predispositions that are being looked at that may also be contributing. So when you're diagnosing, you have to have evidence of fat in the liver. So you have to have hepatic steatosis, either by imaging or histology. The gold standard is going to be a biopsy, but a lot of patients just get imaging. You also have to rule out secondary causes. So I hope you can see this table. These are the top are going to be the most common. So you're looking at alcohol, hepatitis. Have they lost a lot of weight recently? Have they had starvation? Have they had TPN? All of these things can cause an increased deposit of fat in the liver. When you are screening for alcohol, the guidelines say about 3 drinks per day for men and about 2 drinks per day for women. So 21 versus 14 a week is what you're looking at. And that is what is considered excessive alcohol consumption. Medications can cause an increased fat in the liver as well. The ones that we're probably going to see the most are steroids, tamoxifen, methotrexate, amiodarone. Those can all predispose to fat in the liver as well. So you always want to do a really good medication history. Why is this so important? I think because we're going to see it more and more, and I see it in my clinic all the time at the VA. So global prevalence, I've seen it up to 40%, but at least 25%. In the US, the prevalence is going up and up as the obesity epidemic continues, our lifestyle. We're going to see it more and more, and we're looking for it more now. The highest prevalence is actually estimated to be in the Middle East and South America with about 30% of the population, and then lowest is in Africa. So again, very prominent, and we're going to see it more and more. So I want to pause there and ask for any questions. If not, then we're going to move on to identifying risk factors. Nina, are there any questions?
Yeah, no questions in the chat yet.
Awesome. So we'll move on. So risk factors for NAFLD. So the established risk factors are going to be obesity, diabetes, hyperlipidemia, metabolic syndrome. So metabolic syndrome, there are 5 different characteristics. And if you have at least 3 of those, which again, a lot of my patients typically do, they qualify as metabolic syndrome. So what are those? I'll just quickly go through. So it's waist circumference, there's triglyceride levels, hyperlipidemia, hypertension, and then last but not least is impaired fasting glucose. So those are going to be important when you're looking at these patients. The most important though is definitely type 2 diabetes and obesity, with type 2 diabetes probably being the most prominent. I'm not sure if you can see my marker, but yeah, type 2 diabetes is definitely what we're going to be talking about the most. I do want to talk about a study that actually helped get some of this data. So not a lot of studies are doing liver biopsy these days. As you can imagine, it's pretty tough to consent someone to a liver biopsy. There was a study done in 2018 at Brooks Army Medical Center where they took 400 patients, screened them, disqualified those that had other causes, had them do an ultrasound. Those that screened positive for steatosis in the liver underwent a liver biopsy. Based on those results, on the ultrasound, you can see here, I want to point out the diabetes, it's very significant, right? So you're looking at those that screen negative at 8% and those that screen positive at 26, pretty significant. And then again, BMI over 30, you're looking at 26 versus 67. So these numbers are pretty alarming. And I think that's, something to really think about when you're seeing your patients. NASH prevalence was a lot higher. So this is biopsy proven inflammation was a lot higher in the Hispanic population. And then specifically, the study commented that as previous studies, they agree that non-alcoholic fatty liver disease is about 60% with those that have diabetes. But in their case, because they actually looked at liver biopsies, NASH was much higher than they even expected, with 22% in those with diabetes compared to non-diabetics at 10, so double. So for some reason, the physiology with diabetes doubles your risk of NASH. So this is where some of this data comes from and some of the risk factors come from. So how will this present to your clinic? These are two of my patients. So 62-year-old lady with obesity, hypothyroidism, and diabetes who came in with an incidental finding on a CT scan of fat accumulation in the liver. And then the other was a gentleman that had labs for completely different, just some screening labs. And then he was found to have elevated AST and ALT. And so he came in to discuss that more. So I will pause there again. Is there any questions, Nina?
Nope, not yet.
Okay, perfect. We'll just keep going. So what do you do when you suspect that your patient has non-alcoholic fatty liver disease, or you have these imaging findings, you have these labs, and you want to figure out, how do you work this up? What do you do in the visit? So I want to give you a framework. So the first thing you want to do is make sure that you screen them for other etiologies of fat accumulation in the liver. Again, that's going to be alcohol, viral, hepatitis, and looking at medications that they may be on. Once you look at those, you document that. And then you really want to think about, is there any other etiologies that may be coexisting for chronic liver disease? So that's where you're going to tailor the rest of your workup. So initially, you want to do some basic labs if they haven't had them yet. CBC, of course, looking at hematocrit and hemoglobin, looking at platelet count, because you're going to see that go down as fibrosis and cirrhotic physiology are more present. Liver enzymes and liver function tests. You want to do iron panel and ferritin on an initial screen, as well as the viral hepatitis screen. And then that can guide your immunization as well later on. But then you want to pause and you want to look at your patient. And what you really want to decide is, who do you think likely may have autoimmune hepatitis versus who do you think is at lower risk? So I think about, in women, I typically check for TSH. I have a lower threshold for autoimmune hepatitis labs. I also typically think about, if they have type 1 diabetes, if they have hypothyroidism, if they have this other autoimmune spectrum that I'm worried about, I will usually check it. I do want to point out that celiac testing is going to be discussed a little bit more in the hepatology literature. It's a really hot topic right now. Because it can be sometimes asymptomatic or minimally symptomatic, they believe that up to 7, even 9% of cryptogenic cirrhosis may be due to celiac. And so you are seeing a lot more testing on that. And I think we'll see a lot more literature come out. Imaging is next. So I would try, if you can, to do ultrasound. CT and MRI have been studied. Depending on if a CT is contrast or non-con, their sensitivity is not great. Non-con is 33%, contrast is 50%. MRI has some minimal studies and has an 88% sensitivity, but their specificity is only in the 60s. Ultrasound is probably going to be the best bang for your buck and the least expensive test. With ultrasound, you're looking at about 85% sensitivity and 94% specificity. So pretty good there. Elastography is a technique where they use vibration and they do it, so it's non-invasive. So they basically send vibration vibes, and then based on the makeup of your liver, the vibrations come back at a certain speed. And then looking at that, they can see whether or not you have fibrosis in your liver. It's a great test to do for these patients. I will say that with elastography as well as ultrasound, your sensitivity does go down if someone is very obese. So something to keep in mind. And then the gold standard is always going to be your liver biopsy. Once you have your initial labs and you're working on your imaging, you want to plug this into a scoring system, what you have, and then that will tell you what the likelihood of this patient having liver fibrosis or inflammation is. And I typically do these two scoring systems, so the FIB-4 as well as the NAFLD fibrosis score, which is NFS, and I do it on MedCalc. So this is what the FIB-4 looks like, and this is what the NFS is. So NFS is a little bit more comprehensive. It takes in the BMI as well as whether or not the patient has diabetes or impaired fasting glucose, whereas the FIB-4 is just 4 different things that you need to plug in. And then based on that, I typically make the decision on whether or not to refer them to hepatology or to elastography. The ASLD guidelines are pretty vague when it comes to when to biopsy. I would also say that I use this as a guideline of when to refer. So patients with increased risk of progressing to NASH or advanced fibrosis, I would refer. So thinking about, you know, do their platelets look concerning? How are their LFTs doing? High LFTs do not necessarily correlate with disease progression or the spectrum of disease, but it is something to think about, especially if they have a high AST to ALT ratio. If someone has high scores on those 2 scoring systems, or if they have an elastography that's higher than an F2, which we'll look at, you typically want to refer. And then if you think there's more than one etiology of their liver disease, if on their labs you're concerned about autoimmune, about hemochromatosis, they have a family history, it's always good to refer for consideration of a biopsy because you don't want to anchor on NAFLD. You want to make sure that they don't have any other underlying chronic liver disease etiologies. There are other scoring systems that are being tested right now, trying to figure out who is at increased risk for NASH or advanced fibrosis. What I've seen that most people will use the most is whether or not they have metabolic syndrome and diabetes. Other things that are being looked at are insulin levels, platelet counts are taken into account. What is their A1C control? How high are their triglycerides? These are all things that are being studied right now, but I would say metabolic syndrome, type 2 diabetes, and then other lab abnormalities that make you concerned for advanced liver disease, I would definitely refer for a biopsy.
Anna, there's 2 questions in the chat.
Yes. Yep.
One refers to this slide. How sensitive are those scoring tools?
Oh, good question. I don't know, actually. Let me see if it's in here. You know, I don't know, but that's definitely something I can look up and see. Yeah, good question.
And then the other question is back when you were talking about labs, are you doing this for everyone with metabolic syndrome or with patients who have elevated transaminases?
Yeah, I would definitely think about it with elevated transaminases, or if they have evidence of fat in their liver, not for everyone. Is that, yeah, good question about the sensitivity. I'll have to look that up. So there's no good, the ASLD or in the Gastroenterology Society here didn't have anything that was a good algorithm that I thought would be easy to follow. Latin America has a good one, but my favorite was actually the British Society of Gastroenterology. So again, you're looking at obesity, type 2 diabetes, metabolic syndrome, look at their other risk factors, think about the medications that they're on, think about their alcohol consumption, check your liver enzymes, also make sure you get some imaging, and then plug it into those 2 scoring systems. And then based on the scoring systems, they give you a risk stratification, and then you can refer them over for elastography, or you can, based on those, you can refer them over for a liver biopsy, or you can just continue to monitor them. So this is a really nice algorithm that I thought we could use for one of our patients that I'll point out that kind of brings it all together. So I can pause there. Are there any other questions?
No other questions. Anisha was just offering that FIB-4 may be best for negative predictive value for HCV, and there's a resource in the chat if anyone.
Okay, great. Yeah, that makes sense. Okay. So this is our first patient. So I'm going to show you kind of how you can do this in clinic and get a good plan for your patient. So this was a 62-year-old female that was found to have steatosis incidentally. She does have a history of obesity, hypothyroidism. She has insulin-dependent diabetes that was decently well controlled, and she was about type 1.5. She was diagnosed, I think, like 40 years ago, but went straight to insulin. And so she came into clinic to discuss this finding. Her BMI was 35. We did a good history. We looked at her risk factors. We looked at her medication. We looked at her alcohol intake. We worked up her labs, and her AST and ALT were actually normal. In her, I did do the autoimmune panel just because of her risk factors. And then also I checked her TSH because she has hypothyroidism. We checked an iron panel, viral screen, and everything was actually normal. So then I plugged in her numbers into the NFS, which gave me intermediate score, and then as well as the FIB-4 did that as well. And so we ended up referring her for elastography. Her elastography, the way that it's reported at the VA, which might be different. So it gives you a FibroScan value up here. And then based on what your diagnosis is down here, it actually tells you like what their score is for having fibrosis in the liver. So hers was actually low, it was 4.5. And if it's less than 7, it's pretty low. So I would refer anybody with F2 or above to hepatology. So with her, we can just continue to monitor and try to optimize some of those risk factors. Case 2, so our 58-year-old gentleman who had elevated AST and ALT also has a BMI of 32. So remembering that study that they did with the liver biopsies, anything over 30 was almost 3 times the risk factor for NAFLD. So for this gentleman also had no concerning factors for secondary accumulation of fat in his liver. We did all of his labs. We ordered an ultrasound, which did show some steatosis. So I plugged him in and using this algorithm. So his NFS score was low, so F0 to F2, but his FIB-4 was actually a little bit higher. And so I usually go with the highest score, and that's what I've talked to hepatology, and they agree, kind of take the highest score and then base your referral off that. And so he did get referred for a FibroScan, which we're waiting to see what that shows. Any questions at this point?
Yeah, a question just popped up. How
Okay.
reversible is fatty liver and NASH with things like weight loss and other treatments of metabolic syndrome and related comorbidities?
I love it. Whoever asked that, thank you. So now we're going to talk about management and what to do. And goal is to lose weight. So most important thing is to lose weight to decrease insulin resistance. 3 to 5% has shown improvement. 7 to 10% can reverse the majority of the features of NASH, and it can actually improve fibrosis. So you want to tell your patients the best thing they can do is lose weight and decrease insulin resistance. The AHD guidelines recommend doing a hypocaloric diet as well as exercise. Exercise alone can be helpful, but there haven't been any studies to show that that alone will actually reverse hepatosteatosis. They also discussed that the best diet per their guidelines would actually be the Mediterranean diet. So this is the most important thing that you can do, is tell your patients to lose weight. We want to get that insulin resistance down. A lot of medications have been studied, so I'll run through these. Let me see. Oh, we're okay on time. So I'll run through these. So ursodeoxycholic has no proven benefit. That's been studied. Liraglutide had an interesting trial in 2016. It was called the LEAN trial. Unfortunately, only had 50 patients. So they had good improvement in NASH in those who receive liraglutide. And they had weight loss, but because it was I think the first study, and it was also only 50 patients. At this time, the guidelines do not recommend starting GLP-1 agonists specifically for non-alcoholic fatty liver disease. Metformin has been studied and unfortunately has had no benefit. There's been a few studies for that, which is really interesting. Next, we have vitamin E. So this is my favorite name of a trial, PIVENS. It was pioglitazone, vitamin E, or nothing special. That was done in 2010. So they looked at vitamin E and saw that it does improve liver histology in non-diabetic patients with biopsy-proven NASH. So that is where you'll see hepatology use this. But again, they have to have biopsy-proven NASH. It's not recommended for biopsy-proven NASH in diabetic patients or in anyone without a liver biopsy. Pioglitazone was studied as well. It does improve liver histology in those with or without diabetes with biopsy proven NASH, but a lot of these patients have had weight gain. And so this is again, something that you might see hepatology prescribed, but only in those that have proven NASH. If they haven't had a biopsy, then there would not be an indication to treat. Also, I don't know if I mentioned, but pioglitazone typically has weight gain, so that can be tough for these patients. And then there is some, you might hear this come up, and again, I didn't dive too deep into this, but pioglitazone has some association with possibly bladder cancer, pioglitazone specifically, none of the other medications in that group. It is very controversial. I think it was initially found in male rats, but something that your patient might bring up. And then vitamin E does possibly predispose someone to prostate cancer. So there's also some research on that your patient might bring up. But again, I think these are patients, if I'm going to consider treating them, I'm going to assume they need a biopsy. So I would refer them over to hepatology. For screening and monitoring, so there are no guidelines for screening at this time. So there is no good treatment like we just talked about besides weight loss. There are no good screening tests. And so there's really no cost effectiveness. So there's no screening. I do think that'll change in the next few years, but as of now, we don't screen for non-alcoholic fatty liver disease. The guidelines do say to practice vigilance in the possibility of NAFLD in patients with type 2 diabetes. And then I think the most important thing is to remember that although these patients can live with fatty liver disease for a long time and they may never progress to NASH, their highest risk of mortality is from cardiovascular events. So all of the risk factors that predispose them to having fatty liver disease, like obesity, hypertension, diabetes, these are all going to cause a lot of cardiovascular pathology. So the best thing you can do is optimize them from the cardiovascular standpoint. And it has been shown that those with NAFLD have increased mortality compared to match control. So it does put someone at increased risk. Patients will develop HCC with cirrhosis, seems to be at a slower rate than those with hep C, but it does happen. Once they develop cirrhosis, then you definitely want to start screening them for HCC and varices per the guidelines. So they go into your normal cirrhotic patient. And as of now, NASH cirrhosis is the third leading cause of transplant in the US for liver transplant, but I presume that'll change because we are seeing it more and more. And I saw it a lot at UW when I was there. So I have a summary slide. Nina, are there other questions?
There is one question from Marina. Do you know why vitamin E is not recommended in patients with diabetes?
I think just the studies that they did when they stratified the data, it didn't show that there was improvement. So this is my summary slide. So I think if anything, like this is kind of what I think about, and this would be what I would take a picture of and just keep it in clinic. So again, check your basic labs and then tailor the rest of the labs to your patient. So not everybody needs to have an autoimmune hepatitis panel. If you're going to refer them over to hepatology, I would probably do it, or at least start the workup. And then I think the guidelines would encourage you to do it on everyone. However, when I talked to Dr. Bess, who does a lot of hepatology over at the VA, she said those guidelines are written by very specific hepatology NAFLD specialists. And so they're a little bit too cautious and too directed when it comes to these, and that in reality, you don't do this on every patient. Imaging, I would definitely go with a ultrasound that's going to have the best sensitivity and specificity. Again, taking into account that if they're very obese, that might decrease your sensitivity. Plug everything into your scoring systems. Remember, the gold standard is always going to be liver biopsy. And then with non-visit consult these days, I would have a low threshold to at least ask if there's anything else that you should be doing. I would definitely refer someone if you have concern for competing etiology. If you think they're high risk for NASH, again, we don't know exactly who those patients are, but diabetes, metabolic syndrome, those patients, if they have NAFLD, I would probably refer them over or at least have them see hepatology once. I did also see an interesting article that said that about 96% of patients undergoing bariatric surgery have non-alcoholic fatty liver disease. So it's pretty impressive. And I think in the future, we'll see bariatric surgery as a way to lose weight also in these patients to be approved. Treatment is going to be weight loss, decrease that insulin resistance, and then optimize their cardiovascular risk factors. That's going to be really important in these patients because they do have an increased mortality compared to patients without NAFLD. And then last but not least, the resources always have to put a plug in for the VA. So they have a great website that you can use even for non-veteran patients. Has some great fact sheets, has a video. The AHD guidelines, if you're in clinic and you get a little bit lost in the shuffle of what to do with these patients, I would pull up these guidelines and just search within them. They're written really nicely and they have summary sections at under each heading that you can just look at. They're bolded. And then I usually print out the patient education handout, the basics for my patients, or send it to them via our communication system. And I think that gives them a really nice overview from up to date. So I would highly recommend utilizing that as well. Okay, that's all I have. Any other questions?
Yeah, there's a couple more.
Yeah.
One, particularly given the cardiovascular risk, what are recommendations on statin use in NAFLD?
Statin use is recommended. Elevated liver enzymes, unless they're like 10, 20 times normal, should not prevent you from starting a statin in these patients. And again, usually these patients will have an elevated ASVD risk. So I would definitely start statins on them and use them.
Second question.
There's no guidelines that statins will treat NAFLD or NASH.
Second question, if the treatment is weight loss, why should we hold back from giving GLP-1?
I wouldn't hold back if you're doing it for weight loss. I would just not do it specifically for their NASH to try to reverse that. I would do it for the weight loss, and then the secondary benefit will be that there just hasn't been enough studies, I think, to recommend it specifically for NAFLD, but it is a very well tolerated and frequently prescribed medication for weight loss. So I would definitely do it in that case. Anisha just posted something, but I don't know what that is. Oh, yeah. Yeah, I think the hottest topics right now, so actually the new gastroenterology head at UW, I think she got hired a year and a half ago, is very into this research and is very well known in the hepatology literature for NASH and NAFLD. So I think we'll see a lot more of this. And yeah, like treatment is huge. Finding a scoring system of those that could progress to NASH is really big. Celiac for an underlying cause is also really big. I think we're going to see a lot more of this because we're already seeing so much of it. So we need to have some better guidelines for screening and monitoring and what to do with these patients.
Any final questions for Anna? Well, thanks so much, Anna. That was great.
Thank you.
I learned a lot. Why don't we take a break, reconvene at 9:50 for Luke's talk.